Good morning, everyone. Today's class is about congenital glaucoma and secondary glaucoma. I am Dr. Sridhar Baratan. I'm professor of the Department of Ophthalmology at Sri Lakshmi Narayana Institute of Medical Sciences, Pondicherry. Let us start with congenital glaucoma. Congenital glaucoma is a rare form of glaucoma, and the affected infants may be born with high intraocular pressure or may develop an increased intraocular pressure within the first week of life, first few weeks of life. Both the eyes are usually involved, but to varying severity. And we found out that male children are affected slightly more frequently than females. Now, the mechanism of action. The intraocular elevation is caused by failure of the anterior chamber, opening of the anterior chamber angle, and the trabecular meshwork to develop appropriately during intraocular development. In these infants, the aqueous humor does not properly drain, but since the production of aqueous humor is nevertheless normal because of inadequate drainage, because of development of the failure or development of the trabecular meshwork, the intraocular pressure is recorded as high. This is an indication just to show you what a normal anterior chamber looks like versus an underdeveloped anterior chamber. As you can see here, this entire thing, which normally should have been open, causing aqueous outflow to happen normally, this entire thing is blocked here, and that's the reason why there could be an increase in the intraocular pressure. As is, look at this area here. It is well open, whereas here you can see that that entire thing, the junction is closed. What are the consequences of increased intraocular pressure? During infancy. Now, depending on the intraocular pressure level, the glaucoma's damage is inevitable after weeks, months, or even years. This basically occurs via the same mechanisms as that in an adult. In addition to optic nerve damage, the globe itself is enlarged because the sclera in the eye of a baby is distensible. It's not as rigid as it is in adult eyes. In babies, in little children, it can be distended. The clinical appearance, as is evident in this picture, is enlargement of the globe. This is also called euphthalmos, and it is directly the result of elevated intraocular pressure. The anatomical landmarks are displaced, the anterior chamber is deep, and all the other segments of the other eye, especially the cornea and the sclera of the outer eye, they expand, principally at the cornea-scleral junction. If you can see that, this is where the whole thing is expanded. However, certain layers of the cornea are not very elastic, and stretching may result in small tears in the cornea. You see that here? These horizontal lines or concentric lines that are visible here. These are also called harp striae, and that causes a certain degree of corneal opacity. See these are the tears in the cornea because of the non-elasticity of the cornea, giving rise to the formation of harp striae. The corneal epithelial edema is caused by elevated intraocular pressure and failure of the corneal endothelial pump mechanism. There can also be epiphora, which is constant tearing, photophobia, which is difficulty in opening the eyes at right eye, and blepharospasm. This is the clinical triad that happens in congenital glaucoma: epiphoria, photophobia, and blepharospasm. If the intraocular pressure is lowered, this opacity is partially reversible. So the mainstay is to lower the intraocular pressure, thereby preventing the opacity of the cornea. As a result of optic nerve damage, along with corneal opacity, children with congenital glaucoma, unless picked and treated early, they will be resigned with permanent visual impairment. You see this is what the opaque cornea looks like in a patient with ophthalmos. This, of course, is a characteristic optic nerve damage that has happened in congenital glaucoma or glaucoma. How do you diagnose congenital glaucoma? Initially is by a clinical examination, of course, with the clinical clues like enlarged eyes, tearing, photophobia, the triad that we talked about. And often these babies also rub their eyes because they're not able to see things properly. And that's the reason why this rubbing actually happens. Now, if congenital glaucoma is suggested, or is suspected, a thorough examination under general anesthesia is necessary. Why general anesthesia? Is to avoid blepharospasm, which is spasmodic closure of the eyes, and to prevent a transient rise in the IOP. And besides measuring the intraocular pressure, anesthesia allows for a thorough examination of all the segments of the eye, and in particular, the optic disc. This is the triad that we were talking about, epiphoria. And you also have corneal edema, which is seen beautifully here. And these are those pictures of Harp's triad, which is tears in the cornea because of the inelastic nature of the cornea. And as you can see here, the attachment or the insertion of the iris is much higher, thereby blocking the trabecular meshwork. And that is the reason why the intraocular pressure will increase. Infantile glaucoma. Infantile glaucoma, also congenital glaucoma. However, the intraocular pressure in this case starts to rise during the first few years of life. Instead of the first few days or weeks, in this case, it is the first few years of life. The cause of the intraocular pressure increase is basically the same as in congenital glaucoma, but it occurs a little later since the anterior chamber angle is more mature than when glaucoma is present at birth. So there might be a few of these, the anterior insertion of the iris, but earlier when the child is born, it was a little bit more mature, so it is able to drain. But as the child grows, then this angle might start functioning or malfunctioning, and thereby giving rise to an increased intraocular pressure. So the IOP may be normal during the first few years of childhood and then may subsequently increase. Juvenile glaucoma, as the name suggests, is where there's an increase in the IOP that occurs in an older child or a young adult. And this condition is often inherited. That is, if there is a history of glaucoma in the parents or the grandparents, it is always better that one actually does a complete examination of the children as well, so as something like this particular entity could be picked up early. Now, during a thorough examination, the ophthalmologist may find discrete evidence of an incomplete maturation of the chamber angle. Clinical features as well as treatment of juvenile glaucoma are quite similar to an adult chronic open-angle glaucoma. What is the treatment? The treatment of congenital glaucoma is primarily surgical. You have different surgical methods according to the degree of the maldevelopment and clarity of the cornea. And these could be a goniotomy, a trabeculotomy, or a trabeculotomy along with a trabeculectomy. So a goniotomy is opening through the gonioscope, you're opening up this particular thing so that you're then able to facilitate aqueous outflow. Trabeculotomy is making an opening in the trabecular meshwork and all 360 degrees across with the help of a trabeculum, thereby opening up the trabecular meshwork and allowing aqueous outflow. And this could be combined with a trabeculectomy, where you do both a trabeculotomy and a trabeculectomy. And there could also be supplemental treatment options like medical therapy, or you could put in an implant, or you could do cyclodestructive procedures. This is a picture of how a goniotomy is done. You make an opening and then use a goniotope and diatrabecular meshwork through this instrument. In trabeculectomy, it's exactly the same as that, wherein you actually have to form a small flap, and then after opening up the entire trabecular meshwork, you also make a punch in the trabecular meshwork, causing an outward flow of the aqueous. A schematic diagram is how a trabeculotomy is done. And this is a picture of implant, which is placed in the sclera, and you can see the tube coming into the anterior chamber, thereby causing, this is an aqueous drainage device, mostly an Emmett's glaucoma valve. This is a picture showing cupping of the optic disc in glaucoma. So as mentioned before, surgical treatment is the mainstay, and goniotomy is done when the cornea is clear, and trabeculotomy is done when the corneas are hazy, but the success rates of both are approximately similar. Trabeculectomy and shunt procedures are only done when either a goniotomy or a trabeculotomy fails. So goniotomy involves making a horizontal incision at the midpoint of the superficial layers of the trabecular meshwork. This may need to be repeated, which would ultimately lead to a success rate of approximately 85%. The results are poor if the corneal diameter is 14 millimeter or more, because those corneas and those eyes, the Schlemm's canal is obliterated. So this is what it looks like. You see the cornea, you see the trabecular meshwork. An opening is made in the trabecular meshwork, and a surgical knife is used to make this particular slit, and it goes all the way around, thereby opening up the trabecular meshwork in order to lower the trochlear pressure. In a trabeculotomy, why is this done? It is if the corneal clouding prevents visualization of the angle when repeated goniotomies have failed, a partial thickness scleral flap is fashioned, and the Schlemm's canal is found, and a trabeculotope is inserted into the Schlemm's canal and then rotated into the anterior chamber. So you push it in and then break it from outside to inside. Technically, it's highly demanding, and it requires prior experience and good anatomical landmarks to achieve predictable results. The Schlemm's canal may be difficult to canalize because of hyperplasia or angle anomalies. A trabeculotomy surgery involves making an external incision and identifying the Schlemm's canal from the outside, and inserting a fine instrument into the Schlemm's canal and breaking through the trabecular meshwork to increase the aqueous outflow. Typically, about 120 to 140 degrees of the trabecular meshwork can be treated by a trabeculotomy in a single sitting. So this is again a picture showing you how the trabeculotomy is done. So instead of it going from inside to outside, you go from outside and you push in the trabeculum here, and then pass it, canalize it across, and then pull it in. You see that? You push it in, and then this is after the canalization is done and the trabeculum worked inside, thereby opening up the trabecular mesh. Congenital glaucomas classification could be either primary or it could be due to an iridocorneal dysgenesis, which is seen in Axenfeld-Rieger anomaly, a Peters anomaly, or an aniridia, and can also be seen in phakomatosis, which is a Sturge-Weber syndrome, or neurofibromatosis type 1. What is Axenfeld-Rieger anomaly? It is usually bilateral with asynchrony, and glaucoma is uncommon. You can see here something called the development of a posterior embryotoxon and the attached strands of iris to the posterior embryotoxon. Rieger's anomaly is autosomal dominant. It could be bilateral but asymmetrical, and glaucoma, incidence of glaucoma is approximately 1 in 50% of patients with a Rieger's anomaly can develop glaucoma. So you could see stromal hyperplasia and correctopia and ectropium uvea. And in this case, full thickness iris atrophy also can happen. So if you see here, the angle anomalies are visible. You can see the attachment is happening, completely covering the angle drainage structures. The syndrome, you can see condition of the Rieger's anomaly, along with dental and facial anomalies as well. Peters anomaly is where you have, it is usually sporadic and is bilateral in 80% of the cases, and glaucoma will definitely happen in 50% of the cases. Here you can see corneal opacity with iris adhesions are noted out here. And you can also see corneal opacities due to lenticular adhesions as identified in this figure. So systematic implications of aniridia. So AN1 is autosomal dominant and isolated. AN2 Miller syndrome is approximately seen 13% of cases. There is, in this case, there is deletion of the short arm of the 11th chromosome. You could also have Wilms tumor, genitourinary anomalies, and mental handicaps. Aniridia type 3 or Gillespie syndrome is very rare. Thankfully, it's only 2%. And it is autosomal recessive. Patients may have mental handicaps and cerebellar ataxia. Signs of aniridia. It could either be partial, subtotal, and you could also have something like a synechial angle closure glaucoma in 75% of the cases, and occasional cataract with subluxation of the lens seen. Glaucoma in Sturge-Weber syndrome. Glaucoma occurs in 30% of patients with Sturge-Weber's, and you could have bilateral to facial hemangiomas as seen, which is noted here, with buophthalmos in 60%. You can make out that the cornea here is definitely slightly larger than it's caused by raised episcleral venous pressure associated with episcleral hemangioma. And the angle anomaly may also be responsible for the increase in the intraocular pressure. And in patients with neurofibromatosis type 1, the glaucoma is ipsilateral to the neurofibroma of the upper eyelid in 50% of the cases. This could be caused by an angle anomaly with or without ectropium uvea. Here you can see the ectropium uvea here. An angle neurofibroma could also cause this particular increase in the pressure, thereby giving rise to glaucoma. To give you an overview of the presentation, what we're going to be talking about are defining secondary glaucoma and its importance, the causes of secondary glaucoma, diagnosis and detection, treatment and management, and conclusion and further future directions. What is secondary glaucoma? It is a form of glaucoma that develops from identifiable ocular or systemic causes. Unlike primary glaucoma, it has a known trigger. So what are the triggers? It could be. So a basic review about the anatomy. This is how aqueous is produced from the ciliary body, and it flows upwards and outwards anteriorly from the behind the iris to the anterior chamber, where it is drained via the trabecular meshwork and the Schlemm's canal. What is the importance of identifying secondary glaucoma? Most important is that timely recognition helps prevent irreversible optic nerve damage, and the management involves treating the glaucoma and the underlying causes. The causes of secondary glaucoma are based on, can be broadly classified, traumatic, inflammation, tumors, and neovascularization. So, main cause being trauma. So basically, it could be blunt trauma that can cause angle recession, hyphema, or trabecular meshwork damage. There could also be penetrating trauma, which may lead to intraocular inflammation, hemorrhage, or lens dislocation. The mechanism is basically because of blockage of the aqueous outflow due to structural damage or inflammation. Inflammatory causes is basically because inflammatory cells and proteins can clog the trabecular meshwork, and the mechanisms are the formation of posterior synechiae, peripheral anterior synechiae, trabeculitis, and steroid response from treatment of uveitis. Tumors. So you could have primary ocular tumors like iris or ciliary body melanoma, which can compress and the drainage structures, or you could have metastasis in the eye, which could cause secondary angle closure or infiltration of the trabecular meshwork. Mechanisms could be direct invasion, angle distortion, and or neovascularization. Now, neovascularization would be caused because of diabetic retinopathy or central retinal vein occlusion, and these lead to ischemia-induced vascular endothelial growth fractures, release of these VEGFs. And the mechanism could be neovascularization, neovascular membrane formation over the angle structures, blocks the trabecular outflow, giving rise to neovascular glaucoma. Types of secondary glaucoma are explained as follows. Could be because of open angle or closed angle, and these are the various things that could cause it. Most important being pigmentary glaucoma, pseudoexfoliation, Sturge-Weisberg syndrome, so steroid-induced, and closed could be because of intraocular tumors, uveitis, neovascular glaucoma, or iridocorneal endothelial syndrome. Angle closure glaucoma also can happen because of pupillary block by the bending forward of the iris and thereby closing the angle. A classic example would be a phacomorphic glaucoma due to swollen lens. Lens-related non-pupillary block. It could be because of an intumescent or a swollen lens or a dislocated lens. Other causes are tumors pushing the angle closed and uveitis-induced synechiae pulling the angle closed. This explains how a lens-induced glaucoma works. It can cause secondary glaucoma. The other type is open-angle glaucoma, which could be basically steroid-induced, which reduce the trabecular outflow and decreased phagocytosis. Pigmentary glaucoma, where pigment granules from the iris clog the trabecular meshwork, and the other causes are pseudoexfoliation syndrome or post-traumatic angle recession, delayed onset angle recession. You could also have a mixed mechanism glaucoma, where features are both of open and closed angles. It can be seen in advanced uveitis, neovascular glaucoma, and chronic angle closure with open angle elements. How do we diagnose this condition? So you have to go through the basic things like slit lamp Biden microscopy, with which you can identify anterior chamber reaction in the form of cells or flare. There could be hyphema. You should always assess the lens status and rule out cataract or subluxation, and iris abnormalities like rubiosis. You need to do a gonioscopy to evaluate the angle structure, the sine K, neovascularization, pigments, and tumors. And most importantly, you also need to do a tonometry to measure the intraocular pressure. Other techniques are ultrasound biomicroscopy, which helps visualize the ciliary body, the peripheral iris, the lens, and the anterior segmental details, especially when the media is opaque. Or you could also nowadays use something called an anterior segment optical coherence tomography, which is a non-contact imaging of the angle structures and the anterior chamber depth. It is a more quantitative assessment that is available nowadays. Laboratory tests like autoimmune markers, antinuclear antibodies, rheumatoid factor. You should rule out infectious causes like syphilis or toxoplasmosis, and a neoplastic workup is a must if a masquerade syndrome is suspected. This is especially useful in inflammatory glaucomas and in masquerade syndromes. Treatment and management. As far as medical therapy is concerned, the main aim is a dual goal, which is to treat the underlying cause and also lower the intraocular pressure. So how do you lower the intraocular pressure? You can use drugs like beta blockers, you can use prostaglandin analogs, but prostaglandin analog, you've got to be a little cautious, especially when there is active inflammation. Carbonic anhydrase inhibitors can be used, either topical or oral, and alpha agonists. Oral or systemic acetazolamide can be used for rapid intraocular pressure control and systemic steroids for inflammatory causes, but one must monitor the IOP, which could be raised because of steroids. Surgical therapy, the main line is trabeculectomy, which is a filtering surgery, and how it helps that it creates a new drainage pathway to lower the intraocular pressure. It is often done in conjunction with the use of antimetabolites like mitomycin C and 5-fluorouracil in secondary glaucoma. One could also use glaucoma drainage devices, which shunts the aqueous to an external reservoir, and it is effective in neovascular or complex uveitic glaucoma. End stage, especially in cases of painful blind eyes, one could actually do a cyclodestructive procedure, which is with the help of a diode laser. And this works by reducing the aqueous production by directly targeting the ciliary body. Please remember, this is reserved only for refractory cases or eyes with poor visual prognosis. Laser therapy. Of late, there's been an advent of the use of lasers in the treatment of secondary glaucoma. So what one could use is a laser trabeculoplasty, slit lamp, scanning laser trabeculoplasty for open angle types. For example, pigmentary glaucoma, pseudoexfoliation, and steroid-induced glaucoma if the trabecular meshwork is visible. The mechanism of action is it helps improve trabecular outflow. One could also do a laser peripheral iridotomy, which is a first-line treatment in angle closure glaucoma with a pupillary plot. You could also do laser photocoagulation, and this helps reduce the aqueous production in advanced or refractory cases. In conclusion, secondary glaucoma arises from identifiable causes with diverse mechanisms. It could be classified into angle closure, open angle, or mixed types, and it aids in the diagnosis and management. The importance of early detection and treatment is so that it prevents optic nerve damage and irreversible vision loss, and it requires a high clinical suspicion and tailored intervention. Future directions in secondary glaucoma management are advances in imaging, anti-vascular endothelial growth factor therapies, and minimally invasive glaucoma surgeries, also called MIGS. And now the focus is on personalized medicine and early screening of patients at risk. Thank you very much.